Diabetic Neuropathy, presented by Jessica Barrett and Kiara Penceal. This presentation will be covering an introduction to diabetic neuropathy, its impact on humanity, its neurotoxic manifestations, the dose and effect relationship, the molecular mechanisms involved, prevention and therapeutic strategies, and a conclusion of everything discussed.
Okay, so what is diabetic neuropathy? Diabetic neuropathy is a spectrum of chronic and progressive neurodegenerative complications of diabetes. Diabetic neuropathy has clinical manifestations that range from peripheral neuropathies to forms of autonomic dysfunction. It includes cardiovascular, gastrointestinal, and urogenital complications, and it is one of the most common and disabling complications associated with diabetes. This section of the presentation will discuss the impact of diabetic neuropathy on children, adults, and the elderly. As far as the impact of diabetic neuropathy on children and adolescents, neuropathy can occur early in youth with diabetes, even though it was once thought rare. Early signs of diabetic neuropathy include sensory loss, autonomic dysfunction, tingling and numbness, as well as reduced protective sensation in children and adolescents. There are also many major risk factors. These include longer diabetes duration, obesity and metabolic syndrome features, and poor glycemic control. The major complications include development of subclinical neuropathy, association with nephropathy in youth with neuropathy, as well as risk of gait instability, foot ulceration, and motor nerve involvement. Early detection and prevention are crucial. However, diabetic neuropathy has not been very well studied in children and adolescents, so there's a lot more limited data than what it would be in adults. Getting into the impact on adults and elderly, diabetic neuropathy is highly prevalent in adults. At least 50% of adults with diabetes develop diabetic neuropathy. Age also increases the risk of the condition. Incidence rises from less than 50 cases per 100,000 people under the age of 50 to approximately 300 cases per 100,000 people over the age of 75. So age definitely impacts the likelihood of the condition. There are also many major complications associated with diabetic neuropathy. These complications include chronic pain, sensory loss, gait instability, falls, fractures, foot ulcers, infections, as well as amputations. There are also many autonomic problems, including orthostatic hypotension, gastroparesis, bladder dysfunction, and sexual dysfunction. Neuropathy reduces the quality of life and costs the U.S. over $10 billion a year, so there's a very high burden connected to the condition.
Neurotoxic manifestations, an introduction to the neurotoxic effects on the nervous system and other body systems. The nervous system is the main body system affected by diabetic neuropathy. Shown here in this figure, the nervous system is separated into two parts: the central nervous system, which includes the brain and spinal cord, and the peripheral nervous system, which includes all the nerves that branch out. The peripheral nervous system is then divided into sensory, motor, and autonomic. The autonomic nervous system controls involuntary functions of the body. This leads to cardiovascular, gastrointestinal, and urogenital neuropathy. Other body systems that are impacted include the cardiovascular, digestive, and urogenital systems. Structural nerve damage, vulnerability of sensory neurons. Diabetic neuropathy affects peripheral nerves primarily, with sensory neurons being the most vulnerable because their cell bodies are located outside of the blood-brain barrier. Small, unmyelinated C fibers, which carry pain and heat signals, and thinly myelinated A delta fibers, which carry pressure, touch, and cold sensations, are the first to degenerate in diabetic neuropathy. This explains the early signs of burning, tingling, and shooting pains that certain individuals feel. Larger myelinated fibers degenerate later, after the small fibers. Large A-alpha and A-beta fibers, which have vibration and position sensing, undergo demyelination and axonal loss. This causes numbness and imbalance. Studies have described diabetic neuropathy as distal to proximal axonal loss. Diabetic neuropathy causes sensory, motor, and autonomic symptoms. Sensory symptoms include a loss of feeling, numbness or less ability to feel pain or temperature changes, which usually begins in the feet and legs and then spreads. Tingling or burning sensations, sharp, cramping pain, hypersensitivity, sensitive to touch, and ulcers. Motor symptoms include muscle weakness, especially in legs and feet, which leads to a difficulty getting up or walking around. Poor balance and coordination, which leads to an increased risk in falls, and muscle shrinking in severe cases. Autonomic symptoms include cardiovascular, hypotension, which is low blood pressure, tachycardia, which is an abnormally high heart rate, specifically at rest for diabetic neuropathy, loss of warning signs of hypoglycemia, which is a lack of visual warning symptoms that let them know when their blood sugars are low, gastrointestinal, swallowing problems, bowel irregularity, slow stomach emptying, urogenital, bladder dysfunction, and sexual dysfunction. And other symptoms include abnormal sweating and difficulty adjusting their vision. Dose effect explores how the level and duration of high blood glucose levels influences the severity of nerve damage. Dose effect, the basic concept. In diabetic neuropathy, the dose is the level or duration of hyperglycemia, which means high blood glucose levels in the body. The effect is the amount of nerve damage in the body. Glucose almost acts as a toxin itself in this disease. A higher dose of glucose, which is increased HbA1c and increased duration, leads to a greater amount of nerve damage in an individual. A study done in 2020 determined that a higher mean of HbA1c levels was one of the most significant risks of diabetic neuropathy. Dose effect across life stages. This timeline shows the dose-effect relationship in children, adults, and elderly. In children, short-term hyperglycemia begins damaging small nerve fibers, a low dose. Changes are often very subtle and are potentially reversible with early glucose control. In adults, longer cumulative exposure to elevated glucose creates a larger structural nerve injury. Axonal degeneration and demyelination becomes more prevalent. In the elderly, it's a lifetime hyperglycemia dose, along with natural age-related declines in nerve repair. It leads to a higher severity of symptoms if not treated properly. Longer duration leads to more neuropathy in an older individual. Glucose dosage levels. A study done in 2015 examined how HbA1c levels predicted the development of diabetic neuropathy in a cohort of 37,375 adults with type 2 diabetes. However, they did not have neuropathy at the beginning of the study. These participants were followed for an average of 7 years. These were the results. HbA1c levels between 6 to 7% were the lowest risk of diabetic neuropathy, which was the baseline group of the study. HbA1c levels between 7 and 8% had an 11% higher risk than the baseline group of getting diabetic neuropathy. HbA1c levels between 8 and 9% had a 30% higher risk. HbA1c levels between 9 and 10% had a 32% higher risk. HbA1c levels that were greater than 10% had a 62% higher risk. The study showed a clear linear dose-effect relationship. As the HbA1c levels increased, the risk of developing neuropathy increased as well. This confirms that chronic hyperglycemia acts as a neurotoxic dose, damaging nerves over time. The results of the study can be shown here in this graph. The solid line shows the HbA1c levels greater than 10%. It shows that they have a greater risk of diabetic neuropathy compared to the other lines that are the other levels of the HbA1c.
This part of the presentation explains the molecular processes that drive nerve damage in individuals with diabetic neuropathy. Discussing molecular mechanisms, hyperglycemia activates pathogenic pathways. This includes the polyol pathway, hexosamine, PKC, AGE formation. These lead to osmotic stress, reduced glutathione, and increased oxidative stress. Mitochondrial dysfunction leads to impaired ATP production and excess ROS, which is reactive oxygen species, and this contributes to axonal injury and impaired nerve regeneration. Neuroinflammation, including the activation of NF-kappa B, MAPKs, and cytokines including TNF, alpha, IL-1 beta, and IL-6. This causes neuronal and Schwann cell damage. ER stress and impaired autophagy result in accumulation of misfolded proteins and dysfunctional mitochondria. Also, programmed cell death pathways, including pyroptosis, which is inflammatory cell death, apoptosis, and necroptosis, contribute to progressive loss of nerve fibers. In this next section of the presentation, we will be discussing and describing the approaches that have been used to prevent, manage, and treat diabetic neuropathy. As far as prevention strategies go, tight glycemic control has shown to be very crucial in managing diabetic neuropathy and type 1 diabetes. Intensive glucose management prevents or delays neuropathy and type 1 diabetes. However, it's been shown to have a limited effect in type 2 diabetes. There's been little to no benefit of glucose control on neuropathy progression in type 2 diabetes. Also, in preventing diabetic neuropathy, cardiometabolic risk factors have to be addressed. These risk factors include dyslipidemia, metabolic syndrome, inflammation, and insulin resistance. These contribute significantly to neuropathy risk. Also, many changes can be made just to lifestyle to help either manage or prevent diabetic neuropathy. These lifestyle interventions include diet, exercise, and weight management, and this helps to improve nerve function and reduce metabolic stress. And lastly, regular screening. It's important to have routine neuropathy evaluations, including monofilament testing and foot checks to identify high-risk adults early, so that way it can be managed properly. As far as therapeutic approaches go, there are no widely accepted disease-modifying therapies. Current therapies focus on symptom control rather than reversing the current nerve damage. Core management includes improving glycemic control, managing blood pressure and lipids, and implementing lifestyle changes. So for the first-line treatment for painful neuropathy, the classes include TCAs, SNRIs, and gabapentinoids, including duloxetine, amitriptyline, gabapentin, and pregabalin. These medications are used to treat the pain from the neuropathy versus the disease itself. Opioids are discouraged and are only for severe refractory cases due to risk profile. There are also autonomic neuropathy treatments. So for orthostatic hypotension, midodrine, droxidopa, and fludrocortisone are used. For GI symptoms, diet and pro-motility agents are used to help with those symptoms. And for bladder dysfunction, behavioral therapy is used as a treatment. There are also many emerging therapies that are currently under investigation for diabetic neuropathy, and these include SGLT2 inhibitors, GLP-1 agonists, and agents that target oxidative stress, inflammation, and aid in Schwann cell repair.
Diabetic neuropathy is one of the most common and disabling complications of diabetes, and it affects millions of people around the world. Diabetic neuropathy targets mainly the peripheral nervous system, especially the sensory nerve fibers. This explains the early symptoms of pain, tingling, burning, and numbness in the hands and feet. As the disease progresses, motor and autonomic nerves are damaged, which leads to muscle weakness and issues with their heart, digestive system, and urogenital system. Chronic high blood glucose levels act as a neurotoxic dose, leading to worsening nerve damage over time. At a molecular level, pathways such as the polyol pathway, oxidative stress, and mitochondrial dysfunction are affected. Early detection of high levels of blood glucose in an individual can delay or reduce the progression of diabetic neuropathy. Current treatments focus on symptom management rather than the reversal of nerve damage.